Let's turn to another example of an unexpected diagnosis. These cases can be challenging precisely because they fall outside the usual diagnostic radar.
Our patient is a 38-year-old man who presented with a parotid gland mass. His history was unremarkable, and imaging showed no additional lesions. The parotid mass was resected along with a neck lymph node dissection.
Imaging demonstrates a right parotid mass, and the resected specimen shows a white, firm, cut surface with focal areas of necrosis. Microscopically, there are irregular nests of epithelial cells embedded in abundant fibrous stroma. On higher power, the tumor forms irregular nests composed of cells with clear to eosinophilic cytoplasm. Mitotic figures are present. Importantly, all tumor cells appear morphologically similar, indicating a single-cell population. In salivary gland pathology, identifying whether a tumor has one versus two cell populations is a key step in narrowing the differential diagnosis. Focal duct formation is present, an important diagnostic clue in salivary gland neoplasms. Again, only one cell population is seen. Areas of necrosis are also identified, suggesting a high-grade neoplasm. Multiple cervical lymph nodes are positive for metastasis, showing sheets of similar epithelial cells. Summary of morphology: carcinoma composed of a single cell type. Tumor cells have focal clear cytoplasm, irregular nests in fibrous stroma, increased mitoses and necrosis. There is lymph node metastases. Initial immunohistochemical stains show tumor cells positive for GATA3, pancytokeratin, P63, and P40. They are negative for CK7, S100, SMA, and neuroendocrine markers. Here are some of the stains. AE 1.3 is diffusely positive. P40 and GATA3 show patchy positivity. CK7 is negative. Re-examining the morphology, irregular epithelial nests in dense fibrous stroma with immunoprofile supporting carcinoma with squamous differentiation. Based on morphology and immunophenotype, the main differential diagnoses for a salivary gland tumor with epithelial morphology, squamous differentiation, and positivity for P63 and P40 include adamantonomalaic Ewing sarcoma, NUT carcinoma, hyalinizing clear cell carcinoma, HCCC. Additional stains showed the tumor is negative for NUT and CD99, effectively excluding NUT carcinoma, which is positive for NUT, and adamantonoma-like Ewing sarcoma, which is positive for CD99. The tumor is also androgen receptor negative, excluding salivary duct carcinoma. Interestingly, CK56 is negative. However, P40 and P63 are more sensitive and specific markers of squamous differentiation, so CK56 negativity remains unexplained. At this point, HCCC seemed most likely. HCCC is a low-grade salivary gland tumor characterized by the EWSR1 ATF1 fusion, and morphologically it resembles this case: irregular nests of clear cells and a hyalinized stroma. However, HCCC typically shows low mitotic activity and rare necrosis, which does not fit our high-grade morphology. Still, due to the certain degree of morphologic similarity between our case and HCCC, FISH testing for EWSR1 rearrangement was performed. The result is positive for EWSR1 gene rearrangement. This result points to a possible diagnosis of HCCC, but our case is high-grade with cytologic atypia, increased mitotic activity, and necrosis, which does not fit with the low-grade HCCC. Can this be a case of HCCC with high-grade transformation? We did a literature search. There is no such an entity as high-grade HCCC. Maybe this is the first case to be reported, but to prove that, we'd better confirm with gene sequencing. Gene sequencing came back as positive for EWSR1 WT1 gene fusion. This result confirms a diagnosis of desmoplastic small round cell tumor.
This explains the morphologic familiarity we constantly felt when examining this case. We knew we had seen this morphology before, but just could not remember which tumor entity it was. When compared with reference images from the WHO classification, the resemblance is striking.
A Desmond immunostain was added for educational purposes and showed the expected dot-like positivity. Desmoplastic small round cell tumor is a rare, aggressive malignant mesenchymal tumor defined by the EWS-R1-WT1 fusion. It predominantly arises in the abdominal and retroperitoneal cavities or pelvis, typically in children and young males. Morphologically, DSRCT is highly characteristic, irregular epithelial-appearing nests set within dense desmoplastic stroma. Remarkably, almost all DSRCTs appear morphologically identical. Immunohistochemically, DSRCT is polyphenotypic and is positive for cytokeratin, desmin, C-terminus of WT1, and neural markers. The prognosis is extremely poor with 5-year survival of 10 to 15%.
DSRCT involving the salivary gland is extremely rare. Including this case, only 7 cases have been reported in the literature. It is likely underrecognized and may be misclassified as poorly differentiated carcinoma or squamous cell carcinoma. Final summary. Desmoplastic small round cell tumor, or DSRCT, is a rare, aggressive mesenchymal neoplasm defined by EWS-R1-WT1 fusion. It typically arises in the abdomen, retroperitoneum, or pelvis. Rare cases occur in the salivary glands, where it may mimic high-grade carcinoma. Despite its rarity, DSRCT has characteristic and consistent morphology, but recognizing it requires a high index of suspicion and molecular confirmation.